So Gift of Life is Michigan's, or our, like, Washtenaw County organ procurement organization. They have blood of the recipients, they have samples.
Oh, okay.
So, and then all the other OPOs have that as well. So that blood, to be completely honest, I'm not sure if we bring that blood to the donor and test it there, but it
Okay.
takes a while to get that testing done. I think that blood gets to us, and our tissue typing lab tests it, which is why it takes a long time. And the safest would be that candidate's blood gets to us. I think that's it. Yeah, I think that it is. So we get it, we test it, we make sure. We are the final decider. The recipient institution is the final decider as to if we accept things or not.
And you do all that before you even make a phone call to the patient?
Not necessarily, no. So factors that affect waiting times are age, blood type, the status on the list, which I'll talk about, and then the PRA. And age has to do with what age do kids die more. So infants are really well protected, so if you're an infant waiting for a donor, it can take a long time. If you're school age, that's when a lot of accidents happen and things like that. Even though they are pretty well protected, there's more accidental deaths. And when you're an adolescent, you have more car accidents and things like that. Once you turn 18, if you are listed before your 18th birthday, then you're listed as a pediatric recipient, and so you will always get preferential look-see to all adolescent donors. If you are 18 or over, up until your 18th year is over, then you are considered an adult at the time of your listing, and then you are competing with all the other adults. And so there are many people waiting as adults, and so your wait time is going to be longer. Your blood type, as I said, we do incompatible transplants as long as your titers are low, up until the age of 1 year, unless we are testing you, and then we'll go a little bit higher, but we've never done that. Your status, there are different statuses for listing people. Status 1A are the sickest of the sick. They are the kids. It's all changing now, so I'm not going to go into specifics because the rules are changing. So status 1A are the sickest of the sick. Status 1B are the really sick but not the sickest of the sick. And status 2s are the sick but not as sick as status 1B or status 1A. And in the pediatric population, you can be a 1A, 1B, or a 2, either staying in the hospital or living at home. If you're an adult, the criteria are very different. If you're in a status 7, that means that you're on hold, meaning that you're still on the list, but you are either too sick and we're waiting to see if you can stay on the list, you have been non-compliant, or you're showing us some reason that you're not really acting like a good candidate right now, so we have to wait and see what you're going to do. Or you're too well, and we're not sure if you're going to stay well enough, but you're too well to accept an organ at this point, but we're just sort of waiting to see if we can take you off the list completely or not. Or you're on vacation, and you have this tremendous thing that you want to do before your organ comes. So those are reasons to be on status 7. Have I missed anything on that? I don't think so. Any questions about the statuses so far? Or you're going for a second opinion, and you're going to another institution, and that way we will put you on hold in our institution until you come back to our institution. You need to be within a radius of 4 hours of our institution at all times when you're on the list, unless you're in a status 7. What status 7 means is that you're still on the list, but we will not entertain any donor organs that come up for you. So if you're going to be going on vacation and you're listed as like a status 1A or a 1B, you better pretty be sure that you really want to go on that vacation, because chances are you will get an organ call at some point, and if you're gone during the time that your organ comes up, that may have been your only opportunity. So that's why we stress the need for going away. And then the PRA, which we had talked about before, if it's really high, we have to restrict the donor pool that we can draw from. Any questions about any of that? The ischemic time, we like to be less than 4 hours. We'll take up to 6. Who knows what the ischemic time is? Anybody know?
Comes out of the heart, body, not
Yep.
pumping.
Yep. It's the time where you harvest the donor organ from the donor, and then you put it into the recipient. So you want to keep that less than 4 hours, because that helps decrease your risk of complications during the surgery plus over time. An elevated PRA, we've talked about prospective cross-match. Some things we can do if you have a high PRA, we can use medications, we can use Rituxan, we can use IVIG. We have a protocol for kids who have super high PRAs and we want to decrease them. The problem is none of the bullets that we have are very good, and they take several exposures to the therapies to really see a change or a reduction in the PRA. And it's not always successful.
I was just thinking of the ischemic time. I'm sure, like, as far as like if someone is in a car accident, but there's like a long delay of like getting them out of a car, you know, like when is all that decision made, like for how long the person may have been dead prior to their harvesting? Like, is that decision not made usually typically until they go to harvest the organ and they can visualize it, or is that?
That is something that is part of the information that our surgeons get when they are accepting the organ. So all of that, that is not included in the ischemic time.
Okay.
There's downtime, which is what you're talking about, and then there's ischemic time.
Okay.
So ischemic downtime is what you're talking about, like the time between the accident or whatever the incident occurred and CPR started.
Yeah.
Or they got on some
Or even
type of
like
support.
yeah, like is there like even if CPR is
Sometimes
in action,
you
like,
don't know.
that can go on a long time. I mean, in some cases, so that's just all.
But that's all part of the if you
Okay.
accept it or not.
Okay.
So when an organ becomes available, and that's potentially fits one of our kids who are listed, then we get that phone call. I don't get that phone call, another transplant coordinator gets that. We call those coordinators procurement coordinators here. In some institutions, that person, that donor, that transplant coordinator does all of that. All of that donor call and everything. I don't do that. I help with the physicians take care of the kids during heart failure, their listing process. I do the evaluations, but I don't take the donor call, and then I do everything else after that. Okay?
You don't take hearts out of dead bodies though.
No. No, what we do is I only say that because I'm like, no way you would ever want me to do that. What we do, we have an explant team that's through the transplant center, who's a team of surgeons and perfusionists, and we send that team to the donor hospital. They will do an initial evaluation to say, yes, this is what was billed to us, and yes, we want to accept it, or no, no, we're not taking this. Then, if they say yes, then the heart gets harvested, and then it gets brought back to us, and anything could happen in between any of that time. And then once the harvest has occurred and we know that that organ is on the way back, that is when the potential recipient is taken to the OR. And then that person is prepared, is opened up, and connections are starting to be undone, and that person is pretty much to the point of no return, and just on the brink of that, and then we wait for that organ to come to the OR. If the organ makes it successfully, then it's brought into the OR. The surgeon will take a look at that organ, inspect it, make sure that it is still in viable condition, and then we'll take it, and then the surgery occurs. If everything goes well, the surgery takes about 5 hours. If not, it can take a little bit longer. Are there any questions about that? These are pediatric transplant volumes, just over time. This is just information to have. It's remained fairly stable over the last several years. Pediatric waiting times, we've sort of talked about this. Status 1A recipients can wait anywhere from days to several months, especially the adolescents and the infants. I was just reviewing some transplant information, and one of our kids who received a heart last year waited for like less than 24 hours. So you never know. It can come, hearts start their time accruing the minute they get on that list. Some other organs, there's like a grace period where you have to wait, but hearts start once you're on that list. In status 2 recipients, like infants can wait days to months, children 6 to 12 months, adolescents 6 to 24 months, but again, once you get put on that list, you better be ready to go. And we talk about this with our families a lot. Like, you may have to wait a long time, but it could come tonight, it could come tomorrow, you don't know. The ABO mismatch criteria we had talked about a lot of. There's a protocol to doing this, but the reason that we have even entertained the idea of doing it is because we talked about there's not a lot of infant donors. So you want to see if you can expand or make that pool bigger. And to do that, we found that you can do ABO incompatible transplants. But there's definitely a protocol for it, and if it would ever happen, we would definitely let you know what that protocol was. It would be on the patient's chart. All of that would be there for you. The biggest thing to remember for ABO mismatch is blood compatibility. And this is where nursing staff really needs to be vigilant when it comes to an ABO incompatible transplant. If a physician orders it because they just don't remember or they didn't know that it was an incompatible transplant, and the blood bank, for some reason it gets by the blood bank, we would need you to be the third check. And then this would be on the kid's chart, it would be everywhere, you would know. The surgical procedure itself is when they do the harvesting, they cut all of the cardiac tissue but the cuff of the left atrium, which contains the pulmonary veins. Yes, so the pulmonary veins stay. The recipient preparation talked about as far as the timing of it, but all except for the heart and the posterior atrial cuff is excised. So they leave part of the atrial cuff because that's what they hook it onto. It is either biatrial or bicable anastomosis. It's usually, we do bicable. For you, when you're taking care of a heart transplant recipient, the protocols are all listed in OTIS, which is the Organ Transplant Information System for U of M. These are the instructions on how to get there. You go to the clinical homepage, and it's the connections section of it. And then you choose OTIS. So if you're looking at it, there's 2 columns, and it's the column on the right side, and it's about halfway down, and it just says OTIS. Then you can log in with your regular level 2 password, and then there's like the OTIS homepage, and on the left side, about 1/3 of the way down, it says the protocol page, so you click on the protocol page. And then it's listed by organs. Hearts are first, and then adults are first, and then pediatrics. So we're the second column of the protocols.
There's a link from our website too.
Right. That's the easiest way to get there. And the pre-transplant lab work, TCT orders, 11 West orders, all of that is in there. Infection management, all of that's in there. Nursing considerations would be post-op issues. During the first few days, we're looking for rejection, infection, the ischemic time, denervation. So the new organ has no nerves that go to it from the recipient because they've all been cut. So you have to rely on the catecholamines, and so when I talk to my families about it, that's like the back road where it needs to go through the bloodstream and it takes a long time. So when you've got adolescents, they can have syncopal episodes if they go from laying to sitting or sitting to standing too fast. So that's something for you to all look at. They're also not going to have heart pain per se. They'll have surgical pain, but they won't have heart pain. So their heart rates will be faster. They're usually between 100 and 120, and that's normal for them, especially early on from transplant. The heart size is something to look for. If you have a smaller heart that was transplanted, meaning there's a lot of space to fill up, the body is going to preferentially put fluid there. We want to watch that fluid because we don't want the heart, we don't want that fluid to become infected, and we also don't want the heart to tamponade. So we're always figuring out, is it just a Cushing or is it something wrong? If it's too big, the kids can come up and their hearts won't be closed, so then they're at even more risk for infection during the first few times. Psychological support, they just got a new organ from somebody who died. It's kind of tough. And I don't say that glibly at all, but that's the bottom line. They all struggle with it. They may not talk about it, but it's there. And there's a lot of guilt that goes around with these families, especially the parents. There's gratitude and there's guilt. It's sort of this odd dichotomy, and I think it's still odd for me working in this field for over 10 years. It's fascinating to me and amazing to me that we can take an organ from someone who's died and put it into someone who's very, very sick, and then it works and these kids are pink and they look great and they can go on to play football and play soccer and do all these things. But it's also very strange at the same time. So there's a lot of, not a lot, but there's like some ethical concerns, there's personal concerns, it doesn't go against any religion per se, but there's still issues that a lot of people have with it. Moving away from that topic, nursing considerations to think about. You want to extubate them early as soon as they're ready. You want to maintain good cardiac output. We want to get immunosuppression instituted. We want to remove all the invasive lines and tubes as soon as possible. It's infection, infection, and infection. Avoid it, avoid it, avoid it. Rejection, rejection, rejection. Avoid it, avoid it, avoid it. Don't like it, don't want it, don't need to have it. Immunosuppressive therapy the purpose of it is to block the response to all foreign antigens. We all know about allergies and our immune system and infection and viruses, bacteria, all of that. Our bodies are super good at fighting off anything that's not ours. Some of us may not feel like that when we get sick all the time, but just think about what you're not getting. So we need to protect our transplant recipients from getting what we're not getting. So what we need to do first is to suppress their immune system. We're not taking it away completely, we're just suppressing it, and we're suppressing certain parts of it. So yes, they still have an immune system, so they can mount inflammatory responses and all, the whole cascade, so they don't get infections. However, they're going to be more susceptible to getting infections. But we also have to suppress them so their body's immune system is sort of stupid and sort of sleepy, so it doesn't go after that new organ. So we use a standard triple drug therapy, which includes calcium urine inhibitors, which is Tacro. We no longer use cyclosporin, but some places do, so you may see kids come through on cyclosporin. Then antimetabolites like Imuran and Cellcept. Again, Imuran, you won't see too many kids on that, but we do see some kids on it, especially if they're transfers now. All of our kids that we transplant here are no longer on Imuran. They've either aged out and gone to the adult side. The ones that we do see on it are from other institutions that have transferred to us. And then steroids. Tacro is a macrolide antibiotic that has immunosuppressant properties. It's the calcium urine inhibitor. The way it works is that it inhibits T lymphocyte activation, although we don't exactly know how it works. The most common side effects: kidney dysfunction, liver dysfunction, tremors in their hands. You may see kids who are first transplanted get these tremors in their hands. It usually lasts about 3 to 4 weeks, and then it gets better. It's their body's becoming accustomed to the drug. Some kids, though, the tremors never go away, or it's an indication that their Tacro levels are too high. Because we're suppressing their immune system, they have an increased susceptibility to viral infections and malignant tumors. They can get headaches, their blood pressure can get high, and they can get hyperglycemic. We initially dose them by their body weight, and then we dose it based on their blood levels. And this is when I get a little crazy, and most of you know how crazy I can get about this. It's much better now. So it's not nursing anymore, it's more the timing of the drug. But what's really important to know as a nursing staff is that if we order a Tacro level, most of the time, like over 95% of the time, it's going to be a trough level. So that means around 12 hours after the previous dose. So because it's a 12 and 12, or it's a 12, works on a 12, it's an every 12-hour drug, you want to draw it between like 30 to 60 minutes prior to the next dose. So that's why I get a little crazy about it. And that's why Regine, the pharmacist, is always telling me what hour trough it is if you're in rounds. She'll be talking to me, she's like, Meg, did you know that that's like a 10-hour trough, or did you know that it's an 11-hour trough? Because it's all in how we interpret it. And the way we know how to immunosuppress people, if this is the trough levels, it's like 9 o'clock in the morning, 9 at night, 9 and 9. The trough level is here, the peak is here, and then it comes down again, and then it's 9, and then you're ready to redose. So this level here, the 9 in the morning, 9 in the morning, 9 in the morning, 9 in the morning, or the 12-hour, 12-hour, 12-hour trough, is the research, where the research has been done. So we know that this is a level that we can make a difference with as far as immunosuppression. Now, the trough levels vary, and they get less the farther out you are from transplant, and also how old you are and what your immune system is like. So generally, we want the trough levels immediately post-transplant to be between 12 and 15. If they're 10-ish, we're okay with that, but usually it's between 12 and 15. The goal is to run the kids on the least amount of immunosuppression because of all the side effects that we can. Does that make sense?
So when you get a trough, it's okay to give them their dose?
Afterwards, yep. That's a really good question. Unless we specify otherwise. So unless they have a high level, and we want that level to come down and just leave their system, we'll want you to give their dose.
So
Because
if the previous level was high, should we take that into consideration and then call you, or you don't just automatically give it? Because you're checking a trough because you want to make sure that you're making an adjustment.
if their level was high, like over 18 or 20, and it's not specified to hold it or not, then please page me. If it's not specified and the level's like 15 or 16, regardless, just page me. If you're not sure about it, just page me. I'd much rather have you page me than not, and give a dose when their level is too high. And that message just hasn't been conveyed. Yeah. Rule of thumb is you will know not to give it. If we're just checking a level, like a routine level, then give it. But if you question it, just call. Other medications can increase the absorption of Tacro, especially like the antifungals. A lot of antibiotics can increase the levels. They can also interfere with the kidney function because Tacro is pretty hard on the kidney. That's the first one listed. Celsect is an antimetabolite, and it selectively inhibits the inosine monophosphate dehydrogenase in the de novo pathway of purine synthesis, producing potent cytostatic effects on T and B lymphocytes.
All
All right.
Exactly what that means.
It just means
This
it works on the
clear-
white blood
clears it
cells
up,
where
man.
the T lymphocytes and the B lymphocytes are. So we gotta watch them.
Okay.
And you have it on your paper. It just means that it works differently than Tacro, and we have to watch different things. So the side effects, diarrhea, leukopenia, which a lot of the kids get, abdominal pain, nausea and vomiting, sepsis, because we're suppressing their immune system, high blood pressure, along with Tacro, along with prednisone, causes high blood pressure, so they typically have higher blood pressures. Hypercholesterolemia, we watch that, and insomnia.
Why is that GI upset?
Because of the way it's absorbed. So we use a lot of Prilosec or Prevacid with them to help prevent that stomach upset. We watch their white blood cells and their platelet counts, and we initially base it on, the dose is based on their body surface area. For those of you who remember, we used to check CellCep levels, and now we don't, because the latest research shows that CellCep levels do not matter as far as the amount of rejection the way Tacro levels do, but the fact that they're getting it does.
All right, Meg, I think my PC